next speaker is Dr. Seema Mital, and she's going to be talking on precision medicine and transplantation care. And Dr. Mital, she's a staff cardiologist and head of cardiovascular research at the Hospital for Sick Children. She's also a professor of pediatrics at the University of Toronto and a senior scientist at the SickKids Research Institute. She leads multiple precision medicine networks in pediatric heart disease, and we're looking forward to her talk. Thank you.
Thank you, Steve. And that was a brilliant talk by Phil. It's a hard act to follow. So I want to thank the organizers, both Simon as well as Lorraine, for inviting me. These are my disclosures. So I want to go back almost 40 years in 1984 when we had the first xenotransplantation of a baboon heart. This is Len Bailey, who in 1984 did a baboon heart transplant in baby Faye, who had congenital heart disease. And unfortunately, within 2 weeks, she died, not surprisingly, of rejection. And you fast forward almost 4 decades later, this is the first genetically modified xenotransplantation from a pig into a human. So this was David Bennett, 57 years old, who was ineligible for a human transplant, but received, and therefore received as a last-ditch effort, received a pig heart that had been genetically modified. 3 genes that would have led to rejection by humans had been knocked out. 1 gene that would lead to excessive growth, that means pig hearts grow very quickly, was switched off. And 6 genes were added to allow human acceptance. But once again, David died within 2 months, related either to some combination of antibody-mediated rejection and latent foreseen CMV infection that had not been recognized, probably at the time of transplant. Nonetheless, it's the first example of what you might consider as a customized organ or a bespoke organ that you can modify in order to be more acceptable to a potential recipient. So when we think about transplant, we're talking about balancing, maximizing organ utilization in the context of limited donors with optimizing or maximizing graft survival in the context of listing more and more patients with increasing medical complexity. So the question is, can precision medicine help? The FDA defines precision medicine as a tailored approach to disease prevention and treatment that takes into account differences in people's genes, environment, and lifestyles. The goal is to target the right treatment to the right patient at the right time. When you think about transplant medicine, that's what we're trying to do. Our goal is to target the right organs to the right patients at the right time. And the journey of a transplant patient is long. It goes from listing after evaluating candidacy to waiting on the transplant list for a suitable organ, to allocation, to surgery, to post-transplant survival. And each of these stages can be marked with significant morbidity or mortality. And I'm going to touch briefly on just a couple of aspects of how some precision medicine approaches can change the way we do things, by looking at artificial intelligence models to predict waitlist mortality, to match donor and recipients, having more personalized organs and more personalized immunosuppression. I won't be talking about biomarkers because we have an excellent talk just following this. I will steal shamelessly from one of the review articles by Mamta had from UHN, where we did a systematic review of machine learning applications in solid organ transplantation, where they looked at studies that had used machine learning to help with organ allocation and with pre and post-transplant survival. We know that currently, so we can't see this, but most of our heart transplant listing, when we put patients on a priority list, it's based almost entirely on prediction of their waitlist mortality. Clearly, that's probably not sufficient. So number one, we need to get the prediction of waitlist mortality right. But we also need to take into account the post-transplant graft survival, so in order to get that priority listing right. So this is a study in 2018 by MedVed, where they took a lot of data from the recipient and from the donors that were available to the recipients during that time period. And they took blood tests, imaging, clinical data. And again, AI being what it is, a bit of a black box, I can't really answer how they did this, but what they did is they used this data to see if they could build a model to predict waitlist mortality and post-transplant survival. And they were able to show that using that model that they made, outperformed the way the organs had been allocated in terms of predicting waitlist mortality. So this model had an 89% area under the receiver-operator characteristic curve for predicting waitlist mortality, a little bit less for post-transplant survival. But what they also predicted was if you were to use this model, you would be able to utilize 124 more available hearts compared to a standard cost regression model. And another example I want to give is based on liver transplants. This was a multi-center study from 11 Spanish centers where the researchers used 64 donor and recipient variables from a set of over 1,000 liver transplants. And for each donor-recipient pair, they looked at 3-month graft survival. And then once again, they built a model to determine if they could find a model that could have better predicted graft survival than the way the organs had been currently allocated. And importantly, they validated their model in a different system, which is in the UK transplant population, which is a different healthcare system. And once again, what they were able to show that using an AI-based organ recipient matching, there was a predicted better graft survival. So this is the ROC for this artificial neural network model, which had an AUC of almost 94% for 3-month graft survival, 78% for 12-month graft survival, and it outperformed the MELD model. MELD is what you typically use for liver disease, assessing the severity of liver disease. And the MELD only model, which is in blue, had a lower performance. The top ranked features in this model were included both recipient and donor features. The recipient features were days on the wait list, the type of liver disease, the MELD score, and the donor, the topmost variables were cause of death, cold ischemic time, presence of hypertension, and the AST levels. Now, these are fairly intuitive that these would affect survival, but it's not, but the human mind cannot compute all of these into an algorithm in order to predict it. And therefore, having something like this may help incorporate more features into the prediction. So that's an example of how AI may help in the future in better allocation of organs and donor-recipient matching. I want to move a little bit towards the latter part of this journey, which is post-transplant care, which hinges a lot on immunosuppression. We know that immunosuppression, we use immunosuppression in a very standardized way, but we also know that all of us carry variants in our genes that influence the way we metabolize drugs. So we know that, which can explain why some patients do better with some drugs than others, why some patients have toxicity while others don't. And if we have this information ahead of time, we can actually use that to guide personalized therapy. This on the left is an article that shows some of the common class of drugs that are used in pediatric populations, most of whom have some gene correlate or drug-gene interactions that influence how the drug disposition occurs. And on the right, I've shown some of the drugs that are commonly used in cardiac patients, for which the Clinical Pharmacogenetics Implementation Consortium has actually provided guidelines for genotype-guided dosing. And one of those drugs is tacrolimus. Tacrolimus is metabolized primarily by the liver CYP3A5 enzyme. If you are an expressor, you're going to metabolize tacrolimus very quickly, and therefore the recommendation is to increase the starting dose by 1.5 to 2 times in order to achieve levels faster. We did a single center study initially where we showed that in addition to CYP3A5 expressor, the age of the patient was also equally important in predicting what the levels would be for a particular dose. So we decided to do a randomized trial, a single center solid organ transplant trial of age and genotype guided tacrolimus dosing, where we took patients, we stratified them into 4 doses. The patients who were young, less than 6 years, and who were CYP3A5 expressors got the highest starting dose, and the older patients who were non-expressors got the lowest starting dose. This shows the comparison against a small study with 53 patients, but you can see here that the time to achieve first therapeutic levels was faster in patients who received age and genotype-guided dosing compared to standard starting dose. There were fewer out-of-range levels, so the less of the yo-yo effect that we often see in patients with the genotype-guided dosing. And importantly, when we looked at the time to achieve stable therapeutic levels in the first month after transplant, 69% of age and genotype-guided recipients had achieved stable therapeutic levels compared to less than 50% in the standard dosing. But that is only explaining a small, 2 factors. We know that many other factors influence tacrolimus levels. So we leveraged the positive study, or the personalizing immunosuppression to improve efficacy study that was launched with funding from the Canadian Donation and Transplantation Research Program. It was a pan-Canadian study. These are all collaborators and investigators of the study, where we recruited over 1,000 recipients and 361 matched donors. In this case, we looked at clinical factors. We looked mostly at the somewhat non-modifiable clinical factors, and that included type of transplant, the age of transplant, were they on concomitant interacting drugs, of course, the tacrolimus dose, and identified which clinical factors contributed to the levels. And then we also did a GWAS and identified a locus that involved 26 SNPs that included CYP3A5, but also many other SNPs that seemed to be associated with tacrolimus levels. We did a machine learning model where we selected the top 15 variables, and we built a model to see how well it would predict tacrolimus levels, that would dose adjusted tacrolimus levels. And we were able to show that the combined model in green of SNP and clinical had a lower prediction error than the clinical only model in red. And it explained 30% of the variation in tacrolimus levels compared to 18% with the clinical model. And this model seemed to perform best in heart recipients compared to kidney or liver recipients. So again, not perfect. It only explains 30% of the variation, but it shows that maybe one can add to this model, add some other features like the liver function or the hemoglobin levels or albumin levels, etc., to make this model better. Having said that, with this background, we are now doing routine pharmacogenotyping in all patients who are being evaluated for transplant, at least amongst the cardiac patients, where this is with the help of Iris Cohn, who's a pharmacologist. And we get a report on all the CPIC pharmacogenetic variants for which there are clinical guidelines. And this helps us. So we have found patients, we've now over 20 plus or 30 patients where we've done this. This is in the first 4 patients, we were able to determine which patients would benefit from clopidogrel and which ones wouldn't, what should be the warfarin starting dose. These are drugs that we use in patients who require ventricular assist devices. We were also able to determine what their CYP3A5 status was, and therefore guide the tacrolimus to starting dose, maybe even up titration. But I think we have to move further from just the tacrolimus, from drug levels. I think as we're nicely hearing about the immune function, it's important to remember that we use standard tacrolimus levels, but the level of actual immune suppression can be very variable amongst patients. And this is work being done by Simon Urschel. I want to thank him for sharing this slide and his data submitted, I think, to be presented at the ISHLT. And he leveraged the positive network to look at immune function assays at baseline, at 3 months after transplant and 12 months after transplant. And I'm just showing you one, just look at this sort of first graph, for example. This is looking at CD4 activity correlated with tacrolimus trough levels. So of course, as you might expect, the higher the trough levels, the lower the CD4 activity. But if you look at the individual data points, you can see that here's a patient where the drug levels were pretty high, and yet one patient did not show any significant immune suppression, compared to someone in this corner with low levels and yet showed pretty significant immune suppression. This suggests that we can't just assume that tacrolimus levels alone are going to tell us what's happening at the level of the immune system. We need to determine what is an optimal immune suppression, and we need to correlate this with outcomes to see whether it's, what levels are optimal in order to prevent not just rejection, but also prevent side effects like infection or PTLD. Also, when we do all of this, while we look at the microenvironment of the patient, we should not forget the macroenvironment, by which I mean adherence with medications is a big challenge, especially when patients go into the teenage or young adults as they transition to young adulthood. Again, leveraging the positive study, Beth Foster, who was a co-PI for this positive study, recruited patients who were teenagers and young adults from across Canada, and looked at both program level factors and patient level factors that influenced medication adherence. And I'll just draw attention to the program level factors, which included things like close monitoring. If you had close monitoring of blood tests or blood levels, that was associated with better adherence, as well as the average time a nurse spends with the patients in the clinic. These are simple things that at the healthcare system level we can implement in order to modify potentially adherence and modify outcomes, and bring it along with the sort of microenvironment of precision approaches that we're trying to use. And towards the end, I just want to talk about personalized organs. At the end of the day, it's what we all want to get out of this. Okay, the holy grail is to avoid immunosuppression or minimize immunosuppression. Clearly, when we talk about gene editing, that's one way of doing it, where you can maybe match the organ to the recipient's immune status. But you can also make organs that are not biological organs, but organs that have no immunogenic potential and thereby can avoid immunosuppression completely. And one example of that is 3D printed organs. At SickKids, we have a very strong 3D printing program. This is the radiologists and the surgeons, where for complex congenital heart disease, we actually create 3D printed models, which the surgeon can visualize, can even try and practice on before they do a surgery on a patient. But the same approach can be used to make organs that are bespoke, because the anatomy can be very different for one patient with a congenital heart disease versus some other congenital heart disease. And so you could make bespoke organs that are fitted to the anatomy. And I just want to share a video from the Carnegie Mellon University where they've been doing just that.
Realistic models of human organs could help surgeons train and practice before they cut into a patient, leading to more successful surgeries. However, it's been challenging to make models that are similar in size, feel, and complexity to human organs at an affordable price. Now, researchers have found a way to 3D print a full-size, realistic model of a patient's heart. They report their results in ACS Biomaterials, Science and Engineering. Scientists have previously made 3D printed models of the human heart, but the stiff materials they usually use don't feel or behave like natural tissues. When researchers 3D print soft tissue-like materials instead, the models collapse, making it difficult to reproduce large, complex structures. Iman Mirdamati, Adam Feinberg, and colleagues recently developed a technique called free-form reversible embedding of suspended hydrogels, or FRESH, to 3D print soft biomaterials within a gelatin bath. The bath supports delicate structures that would otherwise collapse in air during printing. The researchers had previously only used the technique to 3D print small objects, but in the new study, they adapted it to make full-size organs. The team chose to make a heart model out of alginate, an inexpensive material made from seaweed that has similar properties to cardiac tissue. First,
So these are exciting times. I like the fact that they were using materials like, naturally occurring materials to do this. And that's something we should keep in mind as we move forward. I do want to talk just the last 2 slides about the challenges that we should be aware of, the limitations of what we're calling precision medicine approaches. Especially when we think about the AI models, everyone agrees that there is a black box element to it where it's been criticized for producing an output without a clear explanation. So there is a move towards having more interpretable or explainable AI where you can see the exact features that are contributing to the output of the model. A very important concern is machine bias, especially the systematic underrepresentation of certain groups. And a classic example of that is what I said about the CYP3A5 expressor status for tacrolimus. 80% of white population are non-expressors for CYP3A5. So if we did a study that was entirely mostly using a white population, that would not apply to maybe the Black or the Asian population, because 80% of Black population are expressors, 50% of Asian population is expressors. So if we have to make a model that covers everything, it has to include all ethnicities. Of course, there is the risk of discrimination. When we start using AI algorithms to look at graft survival and don't take into account the social, as we heard, the socially disadvantaged population or the social factors that go into it, we may inadvertently disenfranchise the vulnerable populations from equitable access to these organs. And finally, for these kind of algorithms, implementing them as point-of-care tools with the operators is not a trivial challenge. It actually, to make them decision support tools, there is a lot of implementation science involved. This is, going back to that picture that I showed. This is the news item in Time magazine when baby Faye died. The same day, there was an article about children in Ethiopia dying of starvation. In 40 years, we've come a long way with transplant medicine, but I suspect we have not made a big difference in the basic necessities of life for children around the world. So when we think about customizing and precision medicine care, this is an example of gene therapy. This was the first drug for gene therapy for SMA, for spinal muscular atrophy, where the price point for one injection is $2 million. Today, the price point for the costliest drug on the market is gene therapy for sickle cell anemia, where it's almost close to $4 million an injection. We have to think about affordability, accessibility, and sustainability as we move towards bespoke care for patients. Nonetheless, I think the future is bright. I think there are ways to responsibly and sustainably use approaches that can make more precise and personalized care to improve outcomes after transplantation. So with that, I just want to thank the funders. I do want to thank the CDTRP for funding some of the work that I presented and our positive collaborators. Thank you.